delivery, please shout out or wave if you can't.
Thank you.
For people on the screen, Charlie and Sarah, we have a visitor, member of the public at our meeting, so please speak up and, if necessary, be prepared to be interpreted by me. I have apologies from Kate Lancaster, Katie Cathanas, Tim, and I think Marina's here. Excellent. I think Oliver is otherwise occupied with clinical activity, so we forgive him. And I'd like to start the meeting with a tribute to a member of staff who very sadly lost their life in a motorbike accident recently. His name was Callum Moore. Many of his family work for Manx Care, and it's a really very sad event. He's left a wife and 3 children, and I just would like to take a moment of silence to pay tribute to him. Teresa has done a really lovely eulogy for him in Manx Care messaging, which is in your inboxes for those of you that have access. But our thoughts are with his family. Thank you. And on the board's behalf, Teresa has written to his family expressing our condolences. So thank you. I have no new declarations of interest. The schedule is attached. Has anyone got anything to add to that? No, thank you. And then we have the minutes of the last meeting, which we'll go through. Any comments of fact on the minutes? Page 1, 2, 3, 4, 5, 6, 7, 8. Happy? Thank you. As part of the minutes, we welcomed our new colleague, Professor Tim O'Neill, who's our Director of Social Care and
Safeguarding. Yes, thank you.
Thank you. And you were unable to be at the last meeting in person, so it's very nice to welcome you here around the table.
Thank you very much.
I'm sure you're still in the honeymoon period.
Just about.
But Manx Care's delighted to have you as a member of the executive, so you're very welcome.
Very kind, thank you, Chair.
Matters arising. Elaine, where are we on the matters arising?
Thank you. So the first 2 matters on the schedule have been scheduled for boards later in the year, and the other action from the QSE committee was for Dr. Khan to be invited to the board to present on antimicrobial stewardship, and he will join us in a short bit.
That's excellent, thank you. Anything else that anyone wants to make a comment on those actions? No? Perfect. I've not been notified of any other business for this meeting. So I think it's now over to you, Tim.
Thank you.
Because I'm very keen that we hear from some of our service users, our workforce and our carers, just to set the tone for what a board in public's all about, which is the public. So Tim, thank you.
Thank you, Chair. So can I welcome with perfect timing? Good morning, Sandra.
Good morning. I'm so glad this isn't a job interview.
You've been misinformed, Sandra. You've been misinformed. Can I welcome Sandra Neal to our meeting? Just take a seat for a second, Sandra. And give the board a very brief introduction. So Sandra, I've met Sandra 2 or 3 times now since I've been in post, and Sandra is a remarkable carer. It's the first thing to say. The second thing to say is that we are very fortunate that Sandra has some very interesting and exciting things to say about the support she's received from our staff in adult social work, and some particular members of staff she may mention. But I think from the board's perspective, it's a really great opportunity to hear from Sandra in terms of her story, the work that she's done, amazing work she's done as a carer over the last few years, and the ways in which I think we can illustrate through Sandra's story some of the best practice I think we're trying to promote and will promote across Manx care moving forward. So I don't want to say any more because I'm sure Sandra has a bit to say, and she's a fantastic speaker. Sorry to say that. And let's really over to Sandra and maybe leave a tiny bit of time for questions at the end.
Okay, that's fine. Yes.
Indeed.
So as Tim said, I was a carer for 6 years, family carer, not as a job. And I was asked to speak to the social workers at the Adult Social Work Day. So I gave an extended version of my story and the benefits that I'd received through social and community care. I'll try and keep this a little bit briefer. Tim has told me that I'm in a Duncan chair, so if I go on too long, I end up in the basement. So I'll just really sort of like outline what happened within my life, how I became a carer for 4 of my family members, the challenges that I had and the way we got around that, and the benefits and the help that I got from you guys. So in 2014, I'd just come back from Australia. My younger brother, had been diagnosed with stage 4 colon cancer, so I'd been out to see how he was. And when I returned, my husband, he suffered an extensive stroke, which left him with permanent communication problems, mobility problems. He also had congestive heart failure, ankylosing spondylitis, so his life was pretty miserable. So our first challenge was how to care for him, I was working, sort of the post-stroke care at that point was pretty miserable. There wasn't an awful lot of support then. I believe it's improved since, but at that point it was pretty awful. So fortunately, my daughter and my brother-in-law were both self-employed, so they were able to help me with the care so that I could carry on working, but obviously on a shorter week. So we managed for probably about a year, I think, without any support from the social and the community care. Mainly, I think, because I wasn't aware of what was available. Any sort of support we were getting was just through our routine appointments with the consultants and such like. And as you know, you go in, have your consult and come out again, and that's the end of it. So we managed okay. It was difficult because, as I say, Danny couldn't communicate anymore. So I became his voice and his decision maker in all aspects of his life. But we managed. But then in 2015, my mum took ill and she was diagnosed with progressive bulbar palsy. So she couldn't swallow properly, she couldn't eat properly. At the same time, my brother in Australia, his cancer had metastasized to his brain, so that was all sort of obviously becoming very distressful. So anyway, Mum went into hospital and she had a peg feed fitted and came home and she was bedbound. My dad, we were both 86 at this point, my dad was quite stressed. So I would try and call twice a day, going to work, coming back to work, in between looking after Danny. Dad couldn't stand working with the peg feed. He was scared of it, you know, so I was on hand. And it was at that point that I realised that I needed help. You know, just couldn't cope with it all. So that's when I reached out to the adult social worker team and enter my angel, Joanne. And from that point, she was part of our family for 5 years after that, and she was invaluable. I mean, caring is very challenging anyway, but to have the support of family and friends and outside influences, it makes it bearable, because it's, I mean, I'm a very confident and capable person, but I was challenged to my limit. And I think without her and the services that she was able to put in place for me, I think I would have been a gibbering wreck. So anyway, so we managed with her. She sort of made sure that they had everything that they needed, and she would call regularly. And then in early 2016, my mum died at home with my dad. They'd been together for 70 years. And my dad was distraught, obviously. So that very same day, he came to live with Danny and I. And Joanne and I supported my decision to care for them both. Again, I had to cut down my hours. So I was now just doing 2 days a week. Dad had lost interest in life. And then 3 weeks later, my brother died. So it was destructive. So Dad he would just sit in his room and just wasn't interested in anything. But Joanne, she was persistent. She'd come and she'd sit with him, she'd talk to him, she'd listen to his stories. And over a period of time, he started to become a little bit more active. So she introduced him to the daycare centre at Peel and live at home scheme. And she also got Peter, I can't remember Peter's name, but he was a social work assistant at the time. And he would call weekly and take Dad for lunch and chat with him, got him involved in the golf club again, so that gave him a little bit of his life back. So she was my anchor. She was just everything that we needed, she put into place. And over a period of time, my dad started to decline. And I think it was 2017, and both Danny and my dad, their health was just awful. So I gave up work completely just to be at home with them 24/7. And his dad's mobility was getting worse. So Joanne arranged for occupational therapy came and they put grab rails around the house. Physio came and gave him a walker. She got hit. They thought he had onset dementia. So she made arrangements for him to see the memory and mental health nurse. So all these things that she put into place, which I would not have known about at all. Danny's health problems were becoming even more complex. His comorbidities were just it wasn't just the different health problems, it was the medications, it was the treatments, things that were working together. So I spoke with Joanne, and Joanne referred me to Sue Wilson, long-term conditions coordinator. She was my second angel. She was just incredible. I mean, time was nothing to her. It could be Saturday, Sunday, 10 o'clock at night. It didn't matter. If I had a problem, she'd be there. So I was very fortunate to have both of them looking after me, really, keeping an eye on me, making sure that I was making the right decisions, because that was my big thing, was I'd become responsible for 2 adults in my life. And I was the one that they were looking to do everything, really. If they were asked a question, they'd look at me, what do I do? So it was having Joanne there as my reassurance. Yes, you are making the right decision. Yes, you are taking the right path. So that was good. And then, fortunately, Danny started some post-stroke seizures, and he had tachycardic event, so he was getting zapped from his ICD and all this sort of thing. So I was sort of like exhausted. Dad, with this onset dementia, was calling out for my mum, so I wasn't getting any sleep. So we then got Crossroads Care involved. So they came along and they would sit with my dad for a couple of hours. So that helped give me a little bit of a break. And at this point, the Western Wellbeing Partnership had been set up. So any issues that I had, Joanne would take to them and they would address them, and she would come back with any solutions. So again, that was very reassuring. Then in 2018, over a period of 3 months, both Dad and Danny had multiple visits to A&E, ended up in hospital. And it was very, very, very difficult. So Joanne said, respite care for my dad. And I said, something that I'd always promised him, I would never put him into care. She can't carry on like this. She said, I can't tell you what to do, but I can see how things have become. So she arranged for him to go into the common home. He hated it, didn't like it at all. So within 10 days, I had him home again, but he had another event, and he ended up in hospital gate at the same time as Danny. So I was going from ward to ward. But Joanne was there still, supporting me, encouraging me, visiting them both. She was amazing. So when Dad was discharged, he didn't want to go back into the common home, so she arranged for him to go into Beaconsfield So he went there for a little while, but sadly Danny had to be air ambulance to Liverpool with a heart problem, and unfortunately, despite several cardioversions and tweaks to his ICD, they said there was nothing else they could do. So he was sent home for palliative care, and for months we had just a frequent influx of health visitors, and then, but unfortunately Dad died. He had a fall and he died, and I wasn't with him, and that's my biggest regret, just not being with him. And Joanna's reassured me, even now, because we stayed friends, even now she said, what could you do? You can't be in two places at once. So it's all the time just having this, not just the practical things that she put in place, but the emotional support. Just having her there saying, yeah, you're doing a good job, you're doing well. So that's really, that is it in a nutshell. I mean, I could go on for ages. There's so many offshoots to that. But Danny died in November 2020, and sort of like we'd been married 47 years, and sort of like after 6 years, the house was empty, there was space, there was nothingness. But Joanne was there, making sure I had grief counselling, had support still, and company. And she was just, I cannot credit her enough with what she did for me, for the things that she put into place. And she even sent me a card saying that it had been a privilege for her to be part of my story. And I said, privilege was mine, because I don't think my sanity would have been intact without her. And everything that we encountered, everything that was put in place, I mean, there were some overlaps between hospital care and social care. Obviously there was some things that were a bit of a blur, but I think that I got more benefit from the at-home care, because you're in hospital, you've got your nursing care, you've got your doctor's care, then you come home and you could be on your own. If you haven't got that support, you could be on your own. So I cannot credit you guys enough with the way that you can support people. Sadly, there's such a lack of awareness in the public domain. People do not realise what you actually do, what they're privy to. More recently, I've got a younger cousin who's got multiple things wrong with her. She lives by herself, and about a year ago, her son got in touch with me, and he said, look, you've done caring, what can you do? My mum's just sitting there waiting to die. She was only 65. So I got involved with her, and because of the experience that I'd had with Joanne and what she'd been able to put in place for me, I was able to get her support, Blind Society, the Deaf Society, Live at Home scheme, occupational therapy, and they've all come and had impact on her life. And she's actually now living life again. And the difference it's made to her is just phenomenal. But I wouldn't have known that. If I hadn't had the experience with my guys, I would not have known what was out there. And this is my passion, to make people aware of what can be done for them. And I think particularly with older people, because they don't want to be a burden, even if they know there's help, oh no, I don't want to bother. They need somebody there to say, well, look, you can have a visit from the physio. She'll help you with your walking. You can have things put. They just don't know, And I really think that awareness needs to be improved to raise your profile so that people know they're not alone. That's the thing. So.
Well, thank you. That was, extraordinary. And I think, more power to you, because you're part of that story. You're very generous in your gratitude to our staff and others, but actually you seem to be the pivot of all of that care. And I think what we're hearing is a real example of integrated care that is person-centred. So boards can sometimes spend a lot of time talking about how we integrate across services and how we integrate with others, but actually the point of you being here is to remind us that it's actually about the individual. And I think that lack of awareness is something we were discussing yesterday. I think there's a real opportunity to have people like you as Manx Care ambassadors. We need to hear from more people like you. I need to give you a platform. So it's really timely that we hear what could have been an awful story, which, you know, for you, what you've been through is extraordinary. But actually, your willingness to go and help other people and to share that story in order to improve care. Thank you so much.
Yeah, well, that's really why I was so pleased when I was invited to talk to you, because if my story and what I experienced and what I benefit from can help others, perhaps others that haven't got a me.
Others.
Pardon?
It will help others. I'm just listening as you were talking there, just how challenging it is looking after people and looking after yourself in that process. But we know that there are so many people in a similar situation. So your story will have a profound impact on other people who might be struggling.
Yes.
And then might come forward and request help and advice that we can provide. I think is hugely important.
And two things. First, thank you so much. Amazing as always, and a bit embarrassing for someone like me who's meant to do this professionally. The second thing is, as you know, we're very keen to work with you moving forward at your convenience. But I think your voice is so powerful and strong and tells such an amazing story. And the strength you've shown is something we'd like to be able to show the people, as Paul's alluding to.
Yeah, well, my time's my own, so my time's your time.
Fantastic.
Thank you.
Fantastic.
So I'm sort of anything, I really, anything that I can do
Thank you.
to sort of, I'd say, raise awareness.
A question from Sarah on the screen.
Oh, I didn't know. Hello.
Hello. I'm sorry I'm not there in person. I had a extraordinary flight that took off from Bristol, circled the island and came home again yesterday. Thank you so much for taking the time to talk to us. I think it's only when we hear directly from people's experience that we can truly learn, and that is incredibly valuable to us. A couple of times you mentioned not knowing what support was available. And I think what I'm hearing from what Tim has just said is that you're willing to help us explain some of the services and what is available to people in the future, which would be amazing. But I just wondered whether you had any initial reflections on how we could make it clearer as to what's available for carers.
Well, when I had a meeting with Tim last week, we did mention doing a promotional video to sort of outline what I'd been through, the challenges that I'd faced, and the solutions, and what the assistance and encouragement that I received from social and community care. So that is one way, I think, perhaps. Another one I did think, when I was at the adult social work day, there was such a passion there, and I was greeted with such friendliness, and I felt that if you could have a day like that now open to the public, I don't know whether it's something that you normally do, but maybe once a year had a social, more social and community rather than hospital based. Although I know there is a continuity there from one to the other, but maybe something like that, because I think people would be really interested in attending it, even if it's only for the coffee and biscuits.
Yeah. Thank you. I think those are both excellent suggestions. Thank you so much.
So, Teresa, then back on the screen to Charlie. Yeah. Teresa, this way. We're making you watch Wimbledon here.
No, thank you. And we do have an annual public event.
Oh, right, okay.
For July, and we'll let you have the date, but if you're available, we would love for you to come along and share your story much more broadly as sort of that first step in getting that broader awareness. That would be marvellous.
Fine.
I think it's the 7th of July, but I wouldn't need to just take the date. But thank you. I think what really was powerful for me was Joanne, and we often sort of, we know we have a range of services. And we have very, very dedicated in individuals, but that relationship, that consistency, and that support, that Joanne was able to provide over a long period of time was clearly invaluable, and we must not forget that in terms of, you know, you've welcomed her into your home and she has felt part of your family, and that's not only the services that we are providing, but the relationship that Joanne has fostered with you and the family. I think it also is really powerful in the role of the wellbeing hub. So we are committed to the wellbeing hubs and local area coordination, which is the voluntary and community sector being very much part of those local models of delivery. And we are now able to progress the Eastern Wellbeing Hub, which has been part of our plan for some time. We've got the West in Peel, we've got the Northern one up at Derby, and we've got the Southern Wellbeing Hub. But I think that reinforces that local connectivity and the eyes and ears in the community, people knowing where they can go for assistance, and the wellbeing hubs having everything under that umbrella, which is able to really help people. So that sort of coordination piece is really, really important, isn't it? Being able to, Joanne knowing exactly who to go to, and being able to do all of that, and those conversations to happen under one roof with all of those professionals, and it just happens. And that's how it should be. That's that seamless, person-centred care that we want to achieve. But
most definitely, that's what I found. I mean, I found with Joanna, she didn't know the answer. She knew where to. She was like a firefighter. You know, she would come in, she'd say, right, I can put out that fire for you. You know, and I think that's the key. And also the fact that she wouldn't voice her opinion per se. She would reassure and she would encourage you, but she wouldn't say, well, I think you should do this, or I think you should do the other. She would just stand and sit on the, because I was always really amazed by the way that, well, everybody that I came into contact with, all the social community care workers, how they can deal with people like us, you know, that have got so much going on and not take it home with them. I said, how do you carry on with your normal life when you're coming into contact with us, you know, and dealing with all our emotion and all our baggage and just sorting it out?
But I'm equally sure Joanne will have taken an awful lot of satisfaction from doing her role in helping you.
And that is something else which I think is very important as well. Giving you public credit. Because as I said to you, it's that sort of like Facebook could become a platform for, like, it's almost like a mob culture, and it's so easy for people to jump on the bandwagon and put negative reports. Oh yeah, I had this, I had that, I did. Very different thing when it comes to credit, and I think we're a very fickle race, aren't we? Sort of like we can have 100 good meals at a restaurant, have one bad one, I'm not going there again. And that's the way we are, you know, and I think we really need to put it out there, the jobs that you guys do, you know, and not look for fault.
Thank you, we'll take that on board. Final comment, query or comment from Charlie.
Thank you, and again, thank you from me for sharing your story of caring for members of your family for many, many years. It sounds like it was a really long journey, and sometimes possibly quite a lonely or isolating one for you. So I work in the world of peer-to-peer support and mutual aid. So bringing people together who have a common interest or a common issue in life and helping them to work together to kind of support each other. So I'm just interested to know if during all of those years of caring, if you were ever introduced to or came across other people like you who were caring for members of their families, and through either kind of carer forums or networks, or was there any networking for you available with other people who are in the same position of you over those years to come together in that kind of peer-to-peer mutual aid kind of support space at all? And if there wasn't, would that be something that you might have welcomed or appreciated at the time?
I'm saying there wasn't, but possibly there was, but I wasn't aware of it. I think because of the person I am, I only ask for help and support if I'm at my wit's end. So I think even if there had been something out there I don't think that I would actually have taken advantage of it. But that's just me. I think there's a lot of people there that would benefit from that sort of networking, to know that there's other people in a similar situation. So yeah, for me personally, probably not. But for other people that I know, yes, I think that sort of thing, knowing that they're sitting next to somebody that's going through exactly the same thing, facing the same challenges, having the same problems, feeling like crying 9 times out of 10. Yeah, I think for other people it probably would work.
Yeah. Okay. Thank you. Thanks for that.
So thank you. It's a huge privilege to have had you here.
That was
You
mine.
are this is only my second board in public as a new chair. So I think it's established the way in which I want to hear stories around Manx care. So you get. I'll always remember you because you're our first. And I think we will be seeing a lot more of you if Teresa gets her way. So thank you very much for finding.
It's been a pleasure. Yeah, and I'll say anything. Just on the end of the phone.
We will take your word on that. So thank you very much indeed.
Okay, you're welcome.
Thank you.
Okay,
Thank you.
see you soon. Okay, thanks. Bye.
Bye-bye.
Thank you.
So, Tim, thank you. That was really timely, I think, given all of the gritty discussions we're having around budgets and everything else. It sort of reminds us what we're here for. So thank you. So we have our next guest at the board. And Paul, you're going to introduce this because this is an item that we've been waiting to hear about. It's an update on the really important issue of antimicrobial resistance and what we're doing about it.
Wendy, it's my absolute pleasure to introduce you to Dr. Rizwan Khan, who's our consultant microbiologist from Manx Care, and has worked very closely with us, particularly the last 18 months, on a project that we found challenging to begin with.
Yeah.
And I don't want to steal Rizwan's thunder, but he's got a really important announcement to make, which I know will be super impressive to the board. But I've invited Rizwan just to talk us through the project and the journey and what we have been able to do in difficult circumstances in a relatively short period of time.
Thank you.
Thank you for the invitation, and thank you for inviting me to brief you on antimicrobial stewardship. Do you have some slides here?
Yes. Rizwan, could you speak up, please? Because we've got a couple of my colleagues on Teams, just so they can hear you as well.
Right. Okay. So we had a pre-antibiotic era when we had no antibiotics to treat infections with, and people would die of complications like sepsis. And then antibiotics came along, and they changed everything. The diagnosis of infection that was more of a death warrant became treatable, and this was no less than a miracle. And we lived with this miracle for almost 70, 80 years now. But unfortunately, this golden period of antibiotics is coming to an end. And we stand today at a threshold of post-antibiotic era, when we won't have antibiotics to treat even the simplest of infections. It may be early days for us, but it's well and truly established in many parts of the world. I would like to draw your attention to these two reports. You don't have to, it is not very clear, but then the gray one is a report from Pakistan, a urine report. They isolated a bug called Klebsiella pneumoniae. And with a high bacterial count, they tested it against 20 odd antibiotics. And surprise, surprise, the only antibiotic that works is colistin. And those of you who have a medical background know that colistin is a very toxic antibiotic. We hardly use it these days. So they have no option. The report next to it is Isle of Man, 2 weeks ago. Urine report, we isolated the same bug, Klebsiella pneumoniae, same bacterial load. We tested it against 20 antibiotics. We were slightly better. We had two options rather than one. Now, with these two options, if this patient was allergic to penicillin or couldn't take oral antibiotics, we were stuck. We didn't have any option. So the difference between the two is only that they in Pakistan see it day in and day out. So it's well and truly established. The problem, they don't have choices. We don't see it as frequently, but if we think that we are isolated and living safely on this island from the rest of the world, and these things won't hit us, or we are immune to these threats, we are sadly mistaken. It's just a matter of time. So this is how big the problem is. Resistance follows the drug like a shadow. We develop a drug, bugs develop resistance. We develop a new drug, bugs develop another kind of resistance. So bugs are always ahead of us. We think we are very clever. They are cleverer than us. But this will continue because resistance is an evolutionary process. Bugs will try to defend themselves by all means. The only thing we can do is we can delay this process. We can contain this process by putting some behavioral changes. And those change of behaviors is what amounts to antimicrobial stewardship. And now the next slide. So what are our expectations from our colleagues? They need to take samples for culture and sensitivity so we know what we are dealing with. They should only prescribe antibiotics if there is a clinical evidence of infection. And we want them to document indication, dose, duration on the drug chart. And also, we want them to review their prescriptions in 48 to 72 hours. That is very important because we can do so many things with this review. We can stop the antibiotics if there's no clinical need. We can switch antibiotics from IV to oral. Now, that is very important as well because giving an IV antibiotic is a risk in itself because you are breaching the skin. The infection can travel upwards. So, and also the cost. Why would you want an IV injection of Cipro for £15 when you can do it for 50p with an oral tablet? So, and oral bioavailability is the same. So this is where the education comes in. We can change from broad spectrum to narrow spectrum, less emergence of resistance. Can I have the next slide, please? So what are we doing? We are monitoring prescribing, and we are also monitoring the resistant patterns. We provide regular feedback to our prescribers. We provide education and training, and all this is complemented by good infection control practice. Next slide, please. So how do we do it? We do, we do daily ward rounds, antimicrobial ward rounds. We started these ward rounds in 2018 when Matt, our antimicrobial pharmacist, joined us. But over the years, we have developed it. And so this gives us an opportunity to interact with our teams. There's no alternative to face-to-face interaction. We go, we talk to them. There is a bedside, educational opportunity. We discuss with our consultant colleagues. We discuss it with our junior colleagues, and that gives, and they listen to us. They respect us. It's a mutual teamwork, and it's working very well. And so almost every prescription on antibiotics written in this hospital is reviewed by microbiologists. And we make 20% of prescriptions, we make some kind of intervention. We either stop antibiotics, we change them from IV to oral, or we suggest something different. So that's a significant percentage. Also, we audit the prescribing practices, and at end of every month, we collate all this data and produce an A4 sheet, a report, not reams and reams of paper, just one A4 sheet. So people look at it and they find, we tell them about the consumptions, antibiotics consumed in the last 1 month. We tell them what are the 3 or 4 top ranking antibiotics that we have been using. We also look at the life-saving antibiotics that are restricted use. They are only used subject to approval. So we need, like meropenem, carbapenems, we don't just dish them out. It's all very restricted. And then also we collect the data on dose, duration, indication, reviews. This is all NICE template. So we work as per the NICE template. So one of the outcomes, 48 to 72 hour review, for example, has improved from less than 40% in 2021 to over 80% in 2024. So that's a huge improvement. Can I have the next slide, please? We also monitor, or this is part of our surveillance exercise, we monitor the resistance data for all the common bugs, E. coli, Staph aureus, and everything. And this helps us to modify or amend our antimicrobial guidelines as per the needs. So this is another success story. Could you please put the cursor on the last, on the set of bars? Yeah. Right. Anyway, so what it is that, if you look at the last set of bars, it's trimethoprim. So in 2000, yes, this one, please. In 2015, we realized that trimethoprim was used in the community for treating urinary tract infections when it was over 50% resistant. So we decided to stop use trimethoprim in community. So we discouraged the GPs from using it, and we canceled the PGD for trimethoprim, the patient group that are there. So you can see that resistance started falling in time. Until very recently, there is a bit of a blip. We need to understand what happened. Maybe new GPs have come, they don't. So that's something. So this works. You see, if you keep rotating your antibiotics, stop antibiotics for some time, things they do tend to work. Next slide, please. Right. So all this data then helps us with working, updating our antimicrobial formulary. We've just launched this antimicrobial guidelines in March this year. This has been extensively reviewed. We had lots of input from our consultant colleagues who use things, because I don't want to produce a document that nobody looks at or nobody is involved with. So, and this is about 200 pages. It has two major sections. One is around antimicrobial guidelines as per the system. And then the other is a general section where we talk about antimicrobial stewardship. We talk about risk, adverse effects of antibiotics, antibiotics used in pregnancy, renal dose adjustments, etc., etc. So this is just at a click of a button. So it's available on intranet, and our colleagues are using it. In terms of education, we have now a permanent slot on Patient Safety Summit. Even if it's 15-20 minutes, we use that opportunity to. We have a permanent slot on doctors' induction on AMS. Kildare knows that if there is a foundation training program and a speaker is missing for some reason, somebody is unwell or can't make it, they would call me, and I would be more than happy to take that slot. So they know it, and we've been doing it for years now. So we go there and we just take that opportunity and talk about infection control, anything. So even at the shortest possible notice. We had an antimicrobial awareness week. We are part of Linkness program. And also nurses, nurses are very happy to see us on the wards. when we cross IV antibiotics. It's less work for them. Yeah. So, focal learning program for pharmacists. Also, we have developed an e-learn module on e-learn Manning. And I was very pleasantly surprised when I was fed back this data that over 70% of our clinical colleagues have already completed it, this optional module, which is again a very good thing. Next, please. Right, this is one of our recent initiatives. Late last year, I went to a conference in the UK, and I was listening to this talk on Global Antimicrobial Stewardship Accreditation Program. So while I was listening to all this, I was saying to myself, well, we do this, we can do this, we have done this. So by nature, I'm not a very optimistic person, but then this was one of the few occasions where I felt optimistic. So as soon as I came back, I went to Paul and I said, I'm very keen to get this accreditation. We need to apply for it. I think we are doing it. So, and Paul was very supportive, and we applied for it. And thankfully, we were accepted. And so now they have sent us a list of standards. So that was, so we will be assessed against 50 standards, almost 50 standards. And so we collected all the information, we collected all the data, and we have already submitted it. Now we are waiting for external assessors to come and visit us. And interestingly, Dr. David Jenkins, who is president of the British Society of Antimicrobial Chemotherapy, will be leading the assessors team himself. So, and when you go onto their website, organizations working towards accreditation, we are there amongst these giants. So that fills you with a bit of pride even before you get accreditation. So I think that's all. Maybe there's another one. Oh, and this is just to thank you, for the recognition we received earlier this year for our work. And I must appreciate Paul that he has had a keen interest in antimicrobials, and he has driven it up the agenda, and we are very grateful for it. Thank you.
Thanks, Rizwan. Could I just build on a couple of things, because Rizwan's been very modest there, very briefly. So under Rizwan's leadership, and including Matt and others who support the process, since 2021, when we started looking at this, the improvement we've made is 1,600% in terms of the 48-hour check, which is phenomenal, and has given us a real boost. And I think that's the reason why we're being selected alongside the giants.
Yeah.
And Rizwan and the team have quite rightly and properly put Manx Care on the international map in relation to antimicrobial stewardship, which is fabulous.
Thank you.
Thank you. So this is a subject to my heart. Obstetrician gynecologists, we're much your worst offenders, I suspect.
No.
And I think, I guess I've got one question, which is a bit of a technical question for the board, but it just fascinates me. I'm really interested in the dilemma we face with the increasing pressure to diagnose sepsis early and to treat early and get antibiotics in early, and the balance with an appropriate prescribing. And that's why I think your 48-hour review is so powerful. But I just wonder, educationally, how are you facing that? I think terrified F2 in A&E with query sepsis and your work.
This is a dilemma faced everywhere, here as well. And on the shop floor, the most junior of our colleagues is on the forefront.
Of course,
you see, and they are trembling in their shoes when they have to make a decision. Sometimes consultant is not available, or So personally, I work very closely with our junior colleagues. So I'm open to I can get a call anytime in the day. And so what we try to do is that, obviously when a patient is coming and there are certain criteria that you follow, but then this, as you said, 24 to, even after 24 hours, because you see the situation now is that normally, patient comes into ED, goes into AMU and moves toward X, Y, and Z. Doctor is not following that patient, but microbiologist and AMS team is. So times we probably at times know a bit more than they would, because we are following the patient through every ward. So if and also I have that advantage of the lab side of things as well. So if there is something that we pick up, we let them know immediately, and we would continue. Otherwise, we would tend to stop. I think it's also a team effort, but this is a dilemma we are faced with at times. But we try to address it as early as we can and stop antibiotics where they're not required.
So from my perspective, I think this is a perfect example of what we want to see at the board, which is great data driving quality improvement, but with great leadership. And I think that would be where all we should be like that. So I think you're an exemplar. So thank you very much. And again, I think just alluding to our previous guest, the combination of very personalised care in the community with the very high risk of a global challenge of antimicrobial resistance just shows the breadth of the work we have to take responsibility for. So thank you very much. That was really helpful. You've got my full support.
Thank you.
And I look forward to hearing about the rollout of this sort of challenge into general practice and the community in due course.
Thank you very much.
Thanks, everyone. That's fun.
So yeah, the latest hot of the news is a vaccine for urinary tract infections, which is going to be very interesting. It's being trialled now. So, but Paul, thank you, because I think I wasn't quite sure why we were bringing this to the board, but I now know why. So I think it's really important that we hear about some of the real challenges that it is our most junior medical and nursing colleagues that face this. But I would like to have a think about the totality of Manx care and what we're doing in dentistry, which is a great prescriber of mod antibiotics, what we're doing in general practice, how we have, so that, for me, that's the next strategic development of this.
I agree, and actually, it's been on my mind. We are probably going to have to put a bit of thought to that, because it's not as easy, I think, engaging some of our colleagues in primary care.
No, definitely not. But it's, I think that sort of level of clinical leadership from someone who's prepared to be available. I mean, microbiologists are worth their weight in gold, and the perception of them sitting in their labs is so old-fashioned, and to have that level of clinical commitment from the senior colleague here is fantastic. Thank you.
Chair, may I, just that story from Rizwan just ticked so many boxes for me on so many levels, really. One, as a frustrated scientist who became an accountant, that's another story. But secondly, from the cost perspective, because we spend so much time at this board talking about money, it's really interesting to look at a situation that really affects patient care and really is an exemplar and a centre of excellence. And it occurred to me that where you have that kind of clinical leadership, there must be other examples where we as an island can encourage that kind of focus in areas that is literally world changing, and literally because we're small enough to get it right. Yes. And we're of a size where, I'm not talking about experimenting on the Manx public, but actually where we can control what we do and see what we do and see immediate results of it. And I thought it was really interesting when he went to the conference in the UK at a world level, and we were already there, and so I think that we should maybe be thinking about how we identify and how we promote this kind of blue sky, big picture thinking, where we really can be a centre of excellence, because that will have a knock-on effect on cost, on how attractive we are as a place to work, attracting big brains, all of those things. And I think it's a really exciting subject.
Yeah, thank you. It's a really timely reminder, Nigel, because I think those links that we have, that sort of spider network, we've still got to value what we do here. And I'm sure, and in fact, I've seen other examples of great practice. So, and again, I think that's the point of bringing things like this to the board. So apologies for running late, but we will crack on, as they say. Is everyone okay to keep going without a break? Yes?
Mhm.
I'm looking around, looking at Charlie and Sarah, who are there. Yes, fantastic. So we're now on to some more of the business type part of the board. So Miriam, we're looking at the BAF, and this time we're looking at the risk around OHR. So over to you.
Thank you. I'm not quite sure how I follow those two stories with something so dry, but I will do my best. So one of the things that I wanted to do with the BAF 3 was provide a much more strategic view of where we are in relation to people leadership, to try and give the board some assurance that we are putting focus onto these areas where we've had some challenges. When I was first given the BAF 3 to review, it was a conglomeration, that's a long word for this time of day, but of risks at an operational level across our different care groups that had been put onto one page. And the board were regularly saying that they did not feel assured in reality that in terms of people leadership that we were able to unpick some of those things because we didn't have that overview. So what we did, and I've got to thank Paul Edge and Sue Davis for their massively invaluable help with putting this together, because I'm not a risk expert, but what we wanted to do was go back and look and say, okay, what does this board need assurance on in relation to our people leadership? And this is what we came up with. So we started much more from that kind of strategic level rather than trying to do it bottom up in terms of these are the problems we've got. And the biggest issue that we could see that the board needed assurance on was whether or not we had a failure to adapt in terms of our development of Manx Care as an organisation and leading our people, and to be able to deliver a sustainable workforce beneath that, underneath all of those issues that we have with trying to attract people to a small island and retain our staff here. So the 4 operational risks that we could see were that we could fail to deliver due to a third of our workforce being employed externally and stationed with Manx Care. So these are Public Service Commission staff who were stationed employees here. This has caused us numerous issues in terms of leadership and control, in terms of being able to pull our workforce together and lead them from the perspective of being a single arm's length organisation. We are starting to work through some of those things in terms of a sense of belonging, and again, huge amount of work gone on in our social care group in relation to culture and giving people that psychological contract with Manx Care as a separate entity. And there are a number of controls that we've put in place, but this is very early in development. So this is a kind of start point, if you like, to giving us a framework. The next one was around failure to deliver high quality services, financial balance, positive working culture, and integration of services, which are our 4 main objectives, due to a lack of suitably trained, qualified, and competent staff out in the marketplace. So we know that we've got a crisis worldwide in terms of well-trained clinical and social staff. And as a small island in the middle of the Irish Sea, how do we get those people here and keep them? And continue to be able to develop them to be the kind of world leaders that we've just seen with Dr. Khan. The third was a failure to deliver due to a lack of connectivity. Now, this is something that members of the board that have been around since I've been here have known that I've banged on about this the whole time I've been here, that actually that lack of kind of coalescence of all of the excellent work that's going on around different types of people leadership, the lack of connectivity of IT systems, the confusion for people about who are they led by, what are their priorities, how do we train them, how do we develop them. It's because none of it is connected up. And I do think that is partly to do with the fact that we're a 3-year-old organisation that's working at arm's length for the first time and trying to kind of create that kind of consistent approach, that psychological contract. And we're working behind the scenes on trying to connect those IT systems together and to provide that sense of belonging and direction for our workforce. And finally, a failure to deliver due to a lack of corporate control over our professional development and HR matters. And again, part of that is to do with the fact that our organisational development teams sit in one area under the DHSE now. Our HR teams sit in the Cabinet Office, and internally within the organisation, we don't have that kind of central hub of control and that corporate direction. So we're very reliant on our interactions with other organisations to give us that central approach. So that's what we've come up with to present to the board as our kind of start point of a framework. The risks underneath that we're working up in relation to how do we resolve some of those issues without causing more difficulty, and how do we pull together the really excellent work that's going on so that it actually gains traction for our workforce and actually gives us that kind of direction. That will also give us economies of scale and reduction in cost while improving quality. So for me, it just has to be a direction we have to consider.
Miriam, thank you. That was incredibly helpful. I'll take comments from anyone first. Sarah, from a perspective of the People Committee, any comments as the chair of that?
Thank you. I mean, I think Miriam has summarised the risks very well, and this document indeed does that as well. I know that we need to have a broader conversation about support for the whole function of people, not just the human resources part, but the culture part. And I know that that is in train, and Miriam and I have discussed that. So I think at this stage, I've nothing to add apart from how pleased I am that the board has got a director of people on our board working at this level, and it is really making quite a substantial difference to us, and I'm very grateful to Miriam for her very hard work and laser focus on the things that have needed that kind of focus. So publicly thanking you, Miriam, for your professionalism and your attitude. Thank you very much.
Thanks, Sarah. Well said. Any other comments? Nigel, sorry.
Yeah, no problem with you. Thank you, Chair. Thank you. I think I really was heartened by your presentation, Miriam, because I think it's getting the issues on the table that enables us to start to fix them and deal with them. So, you know, where do we go from here? You could almost apply what you've said about people across the piece where we have shared services. And we know that this is a major issue as far as CQC is concerned. We know it's a major issue in terms of our estates. We know it's a major issue in terms of other areas where we rely upon shared services. And that's not to criticise the shared services, because when you get to the people who are working in those shared services, they're brilliant, they're absolutely superb, but the process is not joined up. And I think government took a decision here on the Isle of Man, it might be 15 or 20 years ago, to centralise, to make more efficient the way in which services were delivered across the piece. But that doesn't necessarily work for us as an arm's length organisation. But where it seems to work better is where we employ somebody to manage that shared service. For example, where we have a director of people or we have a director of finance, it works extremely well. And we know there are issues in there, but they're being dealt with and they're being sorted. It will take time, but there's a journey and we're on that path. So I think, you know, where I think we could really learn here is, in short, we're not going to change the shared services model tomorrow. That's going to take time, and government is not going to change that. And even if they decided tomorrow to change it, it's going to take 18 months or 2 years to even implement those changes. So we have to manage it better and manage it more efficiently. But I think for me, the way we could do that is by employing an expert here in this board to manage that shared service more efficiently and better. And particularly in the States, particularly perhaps in GTS, particularly perhaps in other areas where we rely on shared services. I think that's the lesson we should learn.
Could I
Thank you.
come back on
Want to
that,
come back,
Chair?
Miriam?
Yes, just to say, I think that was a really important point you made there, Nigel, because none of this is around criticising the people who are working in the shared services. And there are some really important economies of scale that we can get from remaining in shared services, particularly around those areas that are transactional in nature. I think what's been missing for me and what I've seen over the last 6 months while I've been here is that kind of strategic level direction around this in a kind of professional people sense. So again, not criticising other colleagues who were kind of doing their best, but there wasn't that kind of coalescence of everything, if that makes sense. I think the shared services work very, very hard, but they are very thinly stretched, and they are very kind of, having to be jacks of all trade and masters of none. And in a health and social care setting, you need something a little bit more specific for some of those cultural and strategic direction issues. So I would agree entirely with your point.
Thank you. I absolutely agree with everything that's been said. I'm delighted to see a slightly more strategic overview of the BAF. I'd really like to move away from RAG ratings, which are really crude, to a numerical rating so that we can see whether things are static, going up or down. And that's the conversation, I think, for a board development session. But I do think that the relationship building, so that shared services start to see us as their most important customer, is really important. And Jackie's experience and your experience, I think, it played to that strength of building those relationships. Because I think you're right, it's not something that we're going to see magic wand waves at the moment.
It's a very good
But thank you, Maria, that's really helpful. Any other comments on the BAF? No, thank you. My report is verbal. I'll keep it very brief. This is, I think it's 8 weeks in for me now. I think it's clear that this is a really interesting time for this organisation. First of all, to say thank you to everyone I've met. I'm meeting more and more people, ranging from GP trainees to foundation directors to the chief executive of the government, various ministers. But my regular meetings in the last month have been really focused around budgetary issues, the future of financial modelling, financial strategy. And I just want to pay tribute to Jackie, whose endless patience with me, looking at lines of Excel spreadsheets is really helpful. This is our major challenge, and my chair's report ought to reflect that. And I'm not unaware of how hard that is for not just colleagues in Manx Care, but also colleagues in the department as we start to understand our arm's length status. I think my most interesting meeting so far in the last month in the wider concept of Manx Cares was with the Isle of Man Medical Society, which I met their executive team last night. And Marina, thank you for being there. I felt supported, I felt welcomed. I'm going to join the Medical Society, and I will not be charging that to expenses for the public first. But I thought it was a really helpful conversation to hear things from the perspective of a large group of people who live on the island, who work universally for us if they're in work, but also have a breadth of perspective. It's a society that goes back to 1856, I think. So, for example, that's older than my Royal College of Obs and Gynae. So they are a venerable group. What I think was really interesting was that they're very closely linked with the British Medical Association, the BMA, which has two hats. It has its union hat and it has its professional hat. And that's always an interesting conversation which hat people are wearing. But I thought it was extremely helpful to meet them. I've asked to be invited to wider meetings so I can meet the whole of the membership. And I think it's a relationship we need to think about how we nurture that and what we do with it in terms of sharing, developing, co-producing, and what the benefits to Manx Care of building that relationship might be. So I'm happy to take any questions on what I've been up to. Move on to Teresa's report.
Thank you, Chair. So my report includes the usual horizon scan, which I think I always hugely impressed when I read the horizon scan about how much work is going on in the operational and corporate support areas. I think it's a really important document, and I'm always keen to hear of how we can better use and distribute the horizon scan. So there is that understanding across the organisation of just how much good work is going on. Just to pull out a few pieces from my report. I mean, obviously the vaccine hub has relocated to Summerhill View as a temporary measure, and that SPING programme has commenced. TT planning is something which takes up an awful lot of time and has been underway for a number of months now. I think given the extensive work that has happened in the last 2 years and that continual opportunity to learn and adapt our plans has worked well. Our TT operational plan will be signed up by the executive team on the beginning of the 15th of May. So it doesn't come to the board, but the executive ultimately signs it off. And it is about also ensuring our business as usual activities continue for all of our other patients, and that is a really important part of our operational plan. And we are always at pains to say that all of the staff in Manx Care have a role in TT, because it does disrupt all of our usual services, and our staff go to great efforts to adapt and change how they work in order to make sure business as usual continues. Also, that really important work with our tertiary partners across in the northwest. So planning has been going very well, led by Oliver. For Summerhill View, we have obviously taken over and adopted that building, and we are in that live procurement process to identify a new partner to help provide that service going forward. We have met with staff members again last week to update them. By the time we next meet as a board, we possibly will have identified a partner to work with going forward. But the board can be assured that we have had all the relevant conversations with the stakeholders, and they are all updated on where we are with that programme of work. Some really excellent news in that the CAMS business case has recently been approved. So this business case has been supported by the Department of Health and Social Care, and grateful for their support and input into that business case over the last 12 months, and obviously to Treasury for approving. This is £3.4 million worth of additional funding over the next 3 years to aid the transformation of children's mental wellbeing services for the island. It importantly allows us to progress with the Thrive model, which we have all signed up to, both in terms of Manx Care, but as wider system partners and our stakeholders firmly believe the Thrive model is the right model. It allows us to do all of the early intervention offers that we have committed to, that we feel are absolutely fundamental. So it allows us to put the focus on prevention and early intervention, and there's some work starting immediately in terms of how that looks for our schools. It will allow a single point of access and a very clear entry pathway. It will allow us to expand the offer within core CAMS, and obviously create those closer links. It will be a very large and extensive programme of work, and Tim and I have already had discussions about how we ensure we get the pace. There's been an awful lot of groundwork done in preparation for hopefully a successful business case approval, which we've now got. So we will hit the ground running on the implementation and delivery, but it is important that we have really good oversight and scrutiny of the delivery of this. So we're just giving some thought to how that sits. Also just want to recognise that we held Operation Athena a couple of weeks ago, and this was to Manx. The board will be well aware that where preparedness, resilience and response is being at a very low level of maturity. And this is an area where we have invested. So we have an emergency planning manager. Oliver is the executive lead for this. The event was really well attended and such a lot of learning from this. Over 200 people attended, both from Manx Care and wider government. We have committed to do this as an annual event. So again, huge amount of learning. It will be formally fed back and feed into those plans. And finally, just to talk about the Women's Health Strategy event, which is a very, very positive event. We hosted basically the Four Nations events, some very eminent speakers, including our own Kate Lancaster, who's also an ed on the board. So again, very, very positive feedback. A really, really important event where I know from the feedback, those who attended really welcomed the opportunity to do some learning. Very much integrated care working, some great speakers, and great to sort of showcase the island as we accelerate the work of the Women's Health Strategy in accordance with our mandate. So happy to take any comments or questions on any of my reports, but I want to just pull out those very positive.
Thank you. Any comments from anyone? I feel as a gynaecologist I should comment on the Women's Health Strategy, so I think it's very timely. One of the reasons that Kate is not with us today is that she's in Parliament presenting the English Women's Health Strategy. So I think we're very lucky to have someone of that seniority as a non-executive here. But I do think it's how that positivity from a day like that's fed back into the day-to-day life of people who work in women's health. And that, I think, it's one of those set pieces that I think we need to learn from and decide on where's the energy for other strategies in due course. And I think as a board, we need to reflect on that strategy and think where it fits within our own framework for the next 3 years, where are mandate opportunities for next year. I know the exec team are thinking like that. But they're big set pieces.
Yeah. I mean, one of the things that I find really encouraging is the sort of level of ambition that we are now seeing from our workforce and how they approach some of these opportunities for learning and sharing. Rizwan's ambitions and Paul's ambitions around infection prevention and control, putting ourselves on the world map. The work that Julie Gibney in social care has done on fostering and adoption and bringing Fatima Whitbread to the island, the Women's Health Strategy, us stepping up in terms of the emergency planning space. These are all really, really encouraging signs that our members of staff feel very much empowered and supported to think big, to think ambitious, and to be proud about what we do and how we do it. So I just find that really, really encouraging, because these are all initiatives that have been supported by executives, but very much led by the teams on the ground.
Thank you. Marina.
And I just want to celebrate that as a clinician. It's so important because that's what we're striving for as Manx Care, to be a world leader. That's our ambition, to be the world's best small island healthcare. And I think sometimes we lose that, but we need that ambition to galvanize us, motivate us, and keep us committed. Because at the end of the day, this is what we do. We look after people.
Thank you. Really well said. Nigel.
So may I, Chair, make a slightly pejorative comment? Because, I absolutely celebrate and absolutely delighted to hear these exciting cultural developments that are happening. Because one of our key aims in running this organisation is to win hearts and minds and get our culture and behavioural aspects right, because it's so powerful. And I'm so delighted to hear you celebrate and refer to the fact that there are so many centres of excellence. And yet in the community, I suspect and feel there are still pockets of negativity. And I'm just putting it out there to say, how do we address that negativity? So are the people who are celebrating negativity part of the solution or part of the problem? And how do we win those hearts and minds? How do we talk to them? How do we convince them? Join us, please. Come on this journey with us, rather than being naysayers. And how are we doing on that journey? How do you feel they're doing? Perception rather than objectivity.
I think that's a really important point, and it came up yesterday in our discussions around other issues. And I think, first of all, I think much as it's lovely to have a member of the public here, I think we're not doing ourselves justice by not having our visitors recorded, our thoughts out there. So I do think we need to move to being more visible as a board. I also think we need to perhaps ask Sarah's advice and set up a board development session on how do we talk about good news without it being binary, because we also have to talk about the more challenging and difficult stuff. And we have expertise around our board that can help us frame that. I am very keen to get our own website up and running, because that is a modern form of communication for people. I was completely unaware we had the NHS app here. I just didn't know that. So, because I don't think anyone's ever mentioned it to me. So we've got other things that we can use. But I think you're right, Nigel. I think we need to think strategically as a board about what are the big messages we want to give? How do we give them? I know that Elaine and colleagues are working on a corporate diary for us, so we know when these big set piece events are coming up. I think Kevin, having joined the team, is a major asset in that his contacts could work with the media and the press, but also with other people in government so that they know what we're up to. And I think you're right, there is a balance to how we say, this is what we're doing. Come and tell us why you're not aware of it, don't like it, what you want to do differently. And I think that's something I think the board needs to address over the next few months, is what conversations is Manx Care as an organisation having with its public. So I'm very keen to get into that space. Thank you.
Very quickly, just to say that there's nothing better than feedback. That's our greatest learning. Negative feedback is brilliant because it gives us an opportunity to learn. What we shouldn't do is allow it to practice. That's all I want to say.
Thank you. Well said. So thank you, Teresa. Anything else in your report?
Nothing, thank you.
Everyone else happy? Thank you. CQC update is a standing item on our board. So Paul, thank you very much for the paper. Oh, I'm so sorry. I've skipped a couple of items. Not deliberately. I assure those people waiting for them. We have the committee reports by exception. So the QSE committee, I chaired the last one because Tim was away. The only item that we wanted to discuss here was the routine CQC update, so that's coming up next. So there was no other exceptional reports from that committee. Nigel, FP&C committee.
Yeah, thank you, Chair. So we met last week, FP&C, and the papers are just about out. And you can see that we had a lively and broad-ranging meeting with lots of discussion. Particularly about, I mean, I'm not going to slavishly repeat what is in the papers, but just a couple of points that I'd like to bring to your attention. We did recommend and sign off on a memorandum of understanding with Walton Hospital, which is a great development because it formalized a relationship there with Walton and set the scene for others coming down the pathway to a sort of modern fit-for-purpose MOU, or memorandum of understanding. Secondly, I attended a meeting with the transformation team on activity-based costing. And this was quite an interesting meeting because activity-based costing, or ABC, full of acronyms, this organisation is here, I have to spell them out, but ABC and service line reporting is a fantastic tool to managing cost and managing the way in which we do things. But it's a big issue. And it's a big issue interrogating a nominal ledger which records our costs to make sure that is right. And I think it's worth bringing to the attention of the board that this is a very, very desirable aim, but maybe we're a little immature just yet. And also there's a massive piece of work going on in the Treasury to recast and reset up our nominal ledger systems. So the point was made that it's imperative that there's joined up thinking in that space between any kind of service level reporting system and the Treasury nominal ledger. And of course, these projects are massive. But I was very assured that people are talking about this. It's not going to happen tomorrow, but I think it's a very desirable aim. The other point I think is worth mentioning is that, and Jackie will cover this off in her report, is that our CIP, or cost improvement plans are very, very ambitious this year. They're very ambitious indeed. And, you know, we need to be very excited on that as a board, in that, you know, we received a massive amount of money last year and we received a huge uplift in our budget. So I think to bring this organisation in on budget this year is a real imperative. And to not do so would detract from the core and purpose of what we're doing. And I think would incur the wrath of a number of our stakeholders. I think the other point is that we discussed a lot around primary care, around GPs and around dental contracts. And I think there's a lot of tension in that sort of area, in that it's considered on a number of sides that these contracts are not fit for purpose. And I think that contracts are two-way streets. You know, that you can't change a contract unilaterally. You have to discuss. And I think there was a massive desire to engage more with our service providers, to talk jaw rather than war. And that's a point I wanted to raise. And the other point is something that's already come up in this meeting, is that capital budgets. We have a shared service agreement with the Department of Infrastructure. And although we are trying very hard and putting resources into managing that relationship, there are issues on the horizon with regard to our capital budgets. And I think we need more visibility of that, and we need to raise that more as an item that needs to be brought to the attention of everybody working in that space. Because our infrastructure, our capital budgets, there's a problem on the horizon, and many of our buildings are not fit for purpose. So thank you.
Okay, thank you. Before I come to Jackie for comments, I'll go to Teresa. You want to comment on that?
It was just that final point, Chair, around that concern. And I think we've come up against this when we have tried to vacate buildings where clearly we need to vacate for various reasons. In that, because there isn't visibility on planned preventative maintenance programmes across the government estate and backlog maintenance, we are finding a lot of buildings falling into a really poor state of disrepair, and then not able to be used. So I think it's an untenable situation. A recent event has meant I've re-escalated that to the department to re-engage and assist us in those discussions about how we make sure that we do have fit for purpose estate which is occupied, but also have options when we do need to use alternative estate for whatever reason. It's a real concern.
Thank you. Clearly, and I think it's it goes back to Miriam's point about how we build relationships with shared services where we become their favourite customer rather than waiting for things to happen. So thank you. And I think I know how hard your committee is working at the moment. And I think your point around the break-even budget is well made. And again, one of the things I shared with the Medical Society was the challenge around this is all of our challenges. It's not just Jackie and the finance team's challenge, it's all of us are responsible to this. Thank you. Anything you want to add to that you're not going to pick up in your report, Jackie?
Yes, just on the capital piece, it's just worth noting for the board that we are in discussions with the DOI, the DHSC and Treasury to try and figure out
Sorry, forgive me, what's the DOI?
Department of Infrastructure.
Okay, thank you.
They are the department responsible for maintaining that. So we're having some discussions to try and decipher what the appropriate route to funding and whose roles and responsibilities are in this space, because I think there's, with the creation of us as an arm's length body, there is some confusion in there. And I think the existing processes are quite complex anyway. Some of the recent changes to the Treasury's funding streams and funding allocations in terms of how you access capital and how you access revenue, the separation of those two things has caused us some problems with some of our big capital schemes.
But I think it's just coming on to what's going to come up in the CQC update. I think where it's really translating for us is that you'll see we are being held back in terms of our ability to respond to some of that issue around our estate. We don't have visibility on what the appropriate assigned budget for maintaining Manx Care's estate is. So without that visibility, it's impossible to prioritise. The other thing that's happening is that because that maintenance is not happening, our buildings are falling into disrepair, and then we are having to repair our buildings in order to stay in them. And that money comes out of our Manx Care's own pocket. So we are using our funding for projects and developments and improvements to make up for the shortcomings in the maintenance of our buildings, which is really limiting us in some of the things we want to do.
So we can't have an estate strategy for Manx Care because we don't have ownership. We have to work with others. So that's the space where we've got to develop those conversations.
I wouldn't say that we can't have an estate strategy. We are working on an estate strategy.
Right.
But obviously the implementation and the success of that strategy is heavily reliant on our partnerships with other organisations. And funding is a big element.
Okay, thanks.
So we don't own our buildings, they're owned by the DOI and they're maintained by the DOI. But also our kit in certain places, the replacement strategy and those kind of things. So we have managed to get a list of the properties that we've actually now got. And we would like very much at FP&C to have a space audit, because a consistent message that I receive as a NED is give us fit for purpose space in which to work, in which to live, in which to practice our expertise. Don't give us a corner in a darkened room somewhere,
Yeah. So that seems to be a big emerging strategic theme for us to think through as to where we place that, where we place the emphasis on that. So thank you.
So we are working, we've suggested to a previous board meeting that actually becomes a risk on our back, because it feeds into so much of everything else that we do. So that is a big strategic risk for us. We've established a strategic use group, which is about starting to think about more broadly how we use and utilise our estate. So that's our direction of travel for this year, is just moving forward, understanding what we've got will be the bulk of what we do in this year. And then once we understand that, then we can start to develop and lay in what our needs are and where those gaps might be filled.
Thank you. A really good place to be. No other comments? Thank you. So you pick up the rest in the report. Thank you. Now, Paul, sorry. So just an update from where we were at the last board. Paper, please.
Keep it brief. Chairman, I will take the paper as read. I've made an attempt on this occasion to try and summarise in an easier to read form for the benefit of members. We do go through the detail in the QSC, so without wanting to repeat some of the things I've said, I think the most important graph I'd draw your attention to is the bar chart on page 49 in your bundle. And I can assure the board that since the last time I reported here, we have made further progress on the implementation of the plan. But the plan remains behind trajectory. We have delivered about half of it. We have half of it yet to be done. The areas that explain the gaps at the moment fall into three distinct themes. There are issues that are not being able to be implemented because they are dependent on resources that are either not yet available to us or are in the process of being released, and therefore we haven't been able to implement the action at this point in time. So some of these issues are safety related, in some cases indirectly safety related, but nonetheless important. And I refer in particular to actions that relate to how Manx Care organises its policy framework. And whilst that might feel and sound administrative, actually it's very important for frontline staff to be able to go to one place easily and find what they need. And also there are some funding elements associated with improvements around waiting times, particularly for some diagnostics in CT and MR, which the CQC identified. As Jackie has rightly pointed out, there are some actions that relate to the environment of care, and they are, as Jackie described, in respect of backlog maintenance and the fabric of the building. But in the CQC terms, they also relate to modifications to the building too, particularly in the area of the changes we intend to make to make the frailty unit more dementia friendly. And the stumbling block on that one, if I can say that without any pun intended, is around the flooring, so that we can minimise falls, which is an area that we have a falls risk in. But also some adjustments that need to be made in the emergency department to make it ligature friendly or ligature safe for people presenting in mental health crisis, but also to find a way of being able to segregate adults from children in a manner that would be acceptable to CQC inspectors and to the board. There are some actions where the CQC directed us to put in place an advocacy service, which are subject to further negotiation and funding being made available. Equipment supply and maintenance has been identified. Then there are a group of actions that fall into the scope of needing to be implemented, but Manx Care is dependent upon a third party for that implementation, and that is, as has been discussed before, linking to our partnerships with the Department of Infrastructure, the Office of Human Resources, and the Department of Home Affairs for a number of different things that we are dependent on them for delivery. And then there are a group of actions that fall into the scope of Manx Care being able to deliver and drive, which are to some extent constrained by our capacity to deliver some of those things in the timescales that we've got, and with other priorities that we're trying to address. And we are pushing on all of those fronts to try and get some progress. But as we sit here at the moment, we have made progress, but we are behind trajectory, which I know that yourself and other members of the board are fully sighted on. I'm prepared to stop there and happy to take questions if there are any.
Questions?
Sorry, Tim.
Okay, Chair, just very briefly, just to assure the board, very keen to talk to Paul about the interplay between the work that's happening within the care group I'm responsible for and Paul's work. Synergy is pretty good already, but I still think there's a bit of work we can do there. I know Paul mentioned around policy, procedure and practice. There's some chunky work there we can undertake, which will make our organisation more efficient and effective, but also hopefully save us a bit of money in the long term as well. So we're very keen to get that conversation with Paul, which we'll be doing in due course.
Yeah, so it is quite an operational question, so apologies if I'm not close to the detail, but I know we've talked about this sort of repository for policies and procedures quite a lot. I have seen other organisations make good use of their intranet to be able to adapt and whilst it's not a dedicated system, it is a referenced area of the intranet which everybody has access to. Would that not be sufficient, Paul, in your opinion, to be able to do this? Because I have seen organisations, and we are investing in expanding our intranet and building an internet. And is there an opportunity for us to take that route, which would allow us to achieve this objective through that route?
So that is the route we're taking,
Okay.
Teresa, is to utilise the SharePoint system that exists across the island. And
That's very helpful.
you know,
Yeah.
that is our tactical plan at the moment to deal with that issue.
So we don't need to procure something bespoke.
We initially thought that we should do that, but I think our direction is to try the SharePoint solution and see if that works, which is what we're trying to do.
Jackie, then Nigel.
Thank you, Chair. Just also to draw attention, I notice in the plan here that on the information governance and BI we're showing 0% progress. I think it's important for the board to understand that in that area, the primary response to that is the Manx Care record,
Yes.
and that's a 3 to 5 year project. So given that we know that, I guess there's a question for us in terms of, are we assured that we are doing everything in the space in the meantime to go as far as we can whilst we wait for that piece? And that's something we'll work with Paul and the team on. But it just stands out there as a zero. There's plenty of work going on in the area.
And I think that's important for a board in public to recognise that what we're looking at is progress from a certain point, not that nothing has happened. And I think that's really helpful. Nigel.
Thanks, Chair. It's a sort of slightly follow-up and slightly supplemental from Jackie's, actually, in that I absolutely applaud the work that Paul and his team are doing in this area. And when you look back, the CQC inspection was a quite a brutal exercise actually for everybody concerned at the time, but it set a benchmark. It was a benchmark as to where are we. I grew up in the financial services industry where we have compliance visits from regulators, and often what happens is when you get a compliance visit, a CQC visit, you get a report and then you get a period of time to put it right. My concern is, and I'm interested in your take on this, Paul, is that how long before we have another CQC visit? And whereas I understand that you're doing everything we can, and we are where we are on this journey, and that it's iterative and we can demonstrate improvements, even if we're not there at the sunlit uplands yet, how long before we get another visit? And how long before we get beaten up for not achieving our, if you like, restoration and recovery on the original report? And is this yet another example where we have responsibility without power?
Can I attempt to answer your question in a roundabout way? Sure. And if I don't answer the question, please come back. But I don't know for sure exactly when the CQC will return, but my understanding is that it could be as early as 2025. Perhaps 6 months away from that being a possibility for us. I think I'd welcome the CQC's return, actually. I'd like to be able to showcase what we've been able to achieve in difficult circumstances in a relatively short period of time and from a very low base. I think we should all take pride in being able to showcase that work. There is a really important piece of work, I think, I'd like to encourage the board to lobby on my behalf with the department, which I think is a really important prerequisite for any subsequent inspection. And that is to define the regulations and standards against which we will be inspected in the Regulation of Care Act. Because I think that then determines what it is we have to do to score the goal and get over the line. At the moment, that's ambiguous and based on English standards, which may or may not apply to the island. So that would be a really important, helpful step before inspectors return. In the absence of that, all that we do have is to be able to demonstrate to inspectors what we have done in response to their findings. And I will attempt to put our best foot forward in being able to show that. And in doing that, they will identify concerns about things we've not been able to implement. And I suspect they will bring a fresh pair of eyes and identify things that they'd like us to work on as well, which is why I think the Regulation of Care was so important for us.
Thank you. So just to let people know that don't keep close to this, the UK government has instructed a formal external review of CQC visiting. It's being led by Penny Dash, who many of us know. So I suspect visiting is going to change. And just a reminder that CQC makes demands, but it does its checking by talking to staff and patients and people who are using our services. And they are very new at integrated care system visiting. So we should be helping the CQC and framing what we expect from any further visits. And I'd like to have a conversation with you offline about how we might start to do that. Significant change to the way in which CQC conducts its business when Penny's completed the review. Charlie, very briefly, please, because we're running horribly late. It's my fault.
Yes, I'll keep it brief, Chair. Thank you. Great progress, Paul, given the resources and circumstances that you're delivering this under. I'm just noticing the graph, the CQC action progress graph, and as time's gone on, there's clearly there's now a polarisation, isn't there, where we're either blue or we're red, we're either embedded or we're overdue. I'm just intrigued to hear your opinion on that. Is that due to CQC kind of burnout in the workforce, and does it require an injection of energy or a recall to action, or is it that all of the easier CQC actions have been completed and now you're really into the nitty gritty and the weeds, and the more difficult and knotty actions are the ones that are now outstanding? I'm just interested to know your opinion on that, and hopefully we'll see some green kind of creeping back into the graph. But it's just an observation of the kind of polarisation of status of the CQC actions as time has gone on.
I think, Charlie, thank you for your question. I think it's a combination of the two. There is a reality that we're delivering this plan from a low base with many other pressures being brought to bear on frontline teams who deliver these changes for us. Not least the very real pressure of rising demand for care post-COVID. So that's a reality for us, that this work has to compete with resource and time that with other important. But it's also true that, you know, we can re-energize it, and I think we are doing that. We've really given it some extra attention in the last few months, haven't we, Teresa, and focused people's minds. There might be a point in time where the board might be willing to consider a revisit of some of these actions in the plan where it's not able to achieve, and perhaps inject some realism.
First, please. I think it goes to the quality committee first.
Indeed, but I think there are probably a number of actions we might want to make some recommendations that are adjusted.
Absolutely, and so I think that let's see them sooner rather than later.
Yeah.
In terms of both the financial planning and the strategic planning for this year. Thank you, Paul. Tim, Ofsted update.
Very briefly, Chair, hopefully I'll take a bit of time. So obviously I'm bringing fresh eyes to the report and the action plan that follows, and I'm doing that as we speak. Shout out to Julie Gibbon, who's doing some outstanding work with her team, driving this with limited resources. Key actions, Chair. First, to address the issue around pace, I'll be speaking to the independent chair and other key colleagues to look at that in detail over the next few weeks, and they'll be able to feed back to you on the changes that I'm alluding to in the short report therein. And then also pay particular attention, I think a bit like Paul, actually pay particular attention to the issues where we've got a multi-dimensional approach, so particularly with the department and wider government, where we can move that forward, taking a proactive and positive approach to that. And I'll hopefully report back on progress on that when we meet again. So yeah, to summarise, progress is slower than we wanted to, but yeah, fresh eyes hopefully will bring it some fresh momentum. Thank you.
Thank you. Really helpful, and please reach out for support. Because Ofsted is as challenging as others in many ways.
Thanks for reminding me, Chair.
Yeah, no. But I also think that it's also an organisation in a state of change as well. So
absolutely,
we start shaping some of that in terms of a partnership approach to regulation. I'm very keen on that. Thank you. Right. So we're moving on to the integrated performance report now. I've got this down as Paul and Marina. And then Tim, is that how you want to do this?
Yeah, I will attempt to keep this brief, if I may. Just a couple of highlights I'd like to draw attention to. This is the close of our third year since the inception of Manx. It gave me a really good opportunity just to reflect on what kind of progress we've made, and it's another good year overall, I think, on balance for quality and safety. We continue with strong performance on IPC metric, infection prevention and control metrics. We closed the year with again another reduction on exposure to serious incidents, which allows me to say that since Manx Care began, we have 30% fewer serious incidents here than when we started, which, you know, doesn't in any way diminish the seriousness of the incidents that are flagged to us, but nonetheless, I think reflect the effort and energy that goes into trying to improve the safety of care. We enjoy strong performance on harm-free care across the areas where that's looked into, and we have a strong reporting culture, which is good. That allows us to have low exposure to medication errors involving harm, good mortality review process, good attention to detail on assessing people's risk factors on arrival, particularly nutrition, hydration, which are big factors in the frailty programme. And the level of service user satisfaction has remained buoyant and strong throughout, which is hugely encouraging. Share my areas for development as I go forward in the next few months is to look in more detail and understand what's behind the increase in falls prevalence across the organisation, particularly inpatient falls, which we have seen an increase in. I want to improve the reliability of care in relation to venous thromboembolism risk assessments. I am looking at reducing the frequency of errors involving harm risk medicines, and the venue of care for children who are placed into adult facilities is an area I want to look into.
Thank you. So I think you've brought the falls to the last couple of boards, Paul. So I think thank you for looking into it. But I think what the board, in terms of assurance, would like to know is what's the outcome of that inspection.
We're taking a paper to QSE.
Thank you. Okay. And likewise with the other events, I think it'd be very nice to hear a timeline in terms of the performance reports to when that issue will either be resolved or be escalated in the future. But thank you. That's really comprehensive. Any comments on Paul? No? Marina.
Thank you. Just to talk about effectiveness of the mortality report, level 1 continues to be very high, 98%, making great progress with level 2. Last time I reported 2, we now have identified 30 level 2 reviews, of which 12 have been completed, 8 have been presented to the mortality group. A few new issues are arising. All the mortality reviews are Nobles Hospital, just to be clear about that. They don't include Ramsey because Ramsey patients don't come to our mortuary, so it's something we need to look at. The other thing that we have to look at is supporting medical examiner role going into statute. We really can't complete all the other actions of the medical examiner until that's actually in statute. The medical examiners have met with the coroner, and I have met with Dr. Allinson to talk about the assisted dying bill, and Dr. Allinson has arranged for a call with the coroner and the medical examiners because one of the anxiety was what's going to be put on the death certificate in the event that the bill is passed. So what I am really celebrating is the fact that we're working together rather than in isolation. Thank you.
Thank you very much. Any comments from anyone about that? No, thank you. I think the medical examiner role is increasingly effective in England, so I think it will be a really helpful role for us here. It supports both ways to the public and to the professionals involved. So thank you for pursuing that. It's really helpful. Tim.
Thank you, Chair. Just three comments to summarise. The first is to indicate and just point to some good, solid performance adult social care, despite some uncertainty in terms of leadership and management, which is my second point, which is that I aim to bring greater stability to that in the short term. I'm doing, without boring the board with the details of that, doing some work around that as I come in, and hope to have some positive feedback on that in the coming months. A couple of key roles in leadership positions in adult social care we're keen to stabilise, but I think it's important to just point to the board that performance has remained broadly solid through that difficult time. So it's congratulations to the teams for doing that, though there remain risks. And then the third one is around young people. There are two, I'm sure colleagues have spotted, two outstanding areas for improvement. One is our child protection area, which is an area I want to look at with some pace, and I'll be doing that with Julie and colleagues. And the second is around the child's voice. I could repeat the point with all adults as well, and that ties into the comments I think you were quite rightly making earlier around community feedback, patient feedback, user feedback, and there's a piece of work for us to do that. So those are the headlines, Chair.
Thank you, really helpful. Any comments or questions for Tim? Just a quick question, Tim. I think in terms of child protection and the links with safeguarding, I think if we could add that to the list of just getting a global view when we do a deep dive report into safeguarding, that would be really helpful.
Will do. Thank you.
Which I think we're planning to do sort of soonish.
Definitely soonish.
Thank you.
Thank you.
Any other comments there? Thank you. Oliver.
Yeah, I just got 3 points that I just wanted to raise, positive points around access. First one, just to note that our inpatient and day case waiting list numbers are continuing to hold, and they're both below the baseline levels that we're achieving following the R&R, which is positive. In addition, our waiting list for first outpatient appointment is remaining static. So we were seeing, since Manx Care was established, a month-on-month increase in the number of patients waiting for a first outpatient appointment, but for the last 6 months that's remained static. That's thanks to our ongoing validation of the waiting list. Cancer waiting times, in March, this is the first month that we achieved 75%, but it was actually 78.6% 98.7% of patients received their cancer diagnosis within 28 days of referral. That's a standard that we've been tracking since late last year, and this month is the first, well, March was the first month that we achieved it, and had a sneak preview of the April figures, and we achieved it again, which is great. And then finally, just to note that from a diagnostic access point of view, we have a standard within the mandate to achieve 99% of patients who are referred for diagnostics get seen within 26 weeks. We started off in October monitoring that, and it was 58%. We've now achieved in March 74%, and that's continuing to increase. So we are hopeful that we will achieve the mandate figure by April of next year or March of next year.
Excellent. So access is the thing that everyone cares about, quite rightly, because it's actually it's a lens through which we look at quality as well. So those are really helpful. And just in terms of sharing that data with one of our ministerial colleagues who's very keen to know about cancer data, if I could ask on behalf of the rest of us that you could just reach out and share that data with.
Yeah, sure. If you let me know who it is, then
thank you. I'm just struggling for names at the moment, but I will pull that to the front of my brain. But I think again, being proactive and saying, you asked this 2 months ago, just thought you'd like an update. I think that's going to be really helpful for us if everyone's happy with that approach. Teresa?
Yeah, I think, we can see and we can evidence that our data quality is improving, and we are using data more and more, and that's borne out in the subcommittees, but also we've just recently received a draft report from the Health Services Consultative Committee, who are our external scrutiny, and they are referencing our good solid data quality, improving data quality and improving use of data. I think the one thing where we have recognised we need to push forward on is publishing that and raising awareness with the public about what our waiting times are. And I know recently we've published our diagnostic waiting times, which is really, really helpful. And just making sure that our IPR is reflective of the integrated care organisation, and having a balance between out-of-hospital metrics and hospital metrics. But I think that work is all in development. But I think publishing and ensuring all of our clinicians know what the waiting times are for their specialties is really, really important for that ability to convey some of that. There is still a lot of misconception with the public, and I keep hearing, I'm expecting, I think it might be two years, and it's not. It's often much less than that. So it's important GPs are aware, and it's important our clinicians are aware of the waiting times when they're seeing patients in clinic and treating them.
Yeah, really helpful, and again, it points to the website and the communication and and what's on the app and all sorts of things. So, really, really helpful. Thank you, and thank you, Oliver, because I know getting the data and then translating it for a board are 2 different things. So very helpful. I would like to ask that at the next IPR we really have a look at general practice and primary care and some of the issues there. If you could just put a paragraph in for us highlighting that, because that's an area, again, when the other Oliver is here, it'd be really helpful to just have a little bit of a reflection on that, to help us see it a bit more breadth in that. That would be great, because that's quite challenging for the public as well. So thank you. Ready to move on? Thank you. So now, Miriam, thank you. Update on the workforce and culture.
Yes, thanks, Chair. I'll take much of the paper as read. You can see from the paper that there's a number of work streams which are progressing, but the main area that I'd like to bring the board's attention to is the shift in the leadership of the workforce and culture team. This team is a project. It's not an ongoing team. We do have an organisational development and design team which sits in Cabinet Office, which is part of the Office for Human Resources, but they are 2 individuals for the whole of government. So we get very little resource and support from them. The workforce and culture team as I say, are a project team, and in paragraph 1.2 of the paper, you can see there that it's funded via the Transformation Fund on a time-limited basis until February 2026. So we do not have long with this team, and it's very unclear at the moment whether or not that funding will continue beyond February 2026. In April this year, the Health and Care Transformation Programme transferred in its entirety from the Cabinet Office into the DHSC. And there is a new revised governance structure, which I understand is going through the DHSC board. What we are trying to do within the Workforce and Culture team is align that year 4 project plan that they have with the people and engagement strategy that was approved at the board in September last year. So we are aligning those two plans so that they essentially read the same. That's partly for funding reasons, but also for giving us that strategic, cohesive direction again in terms of what we're doing in the people space. So the year 4 plan for Workforce and Culture is heading through the DHSE board as we speak. And we will be taking that plan through the People Committee next week. On top of that, again, to try and bring this cohesiveness, the team have worked up an organisational development plan for Manx Care, which again is going through the People Committee next week. What that does is pull all of the actions from all of the various different plans that are related to culture change and put them in one place for the board to have oversight of. And if that can align with that transformation planning that is approved by the DHSE, then we will have some clarity in terms of what it is we're actually doing. The actions there listed under the activities are all of the things that are coming out of all of those plans where we just highlighted. Now, I won't go through those in detail. The one area where I am pleased that we've got some traction on, but I want to give it more focus is in terms of equality, diversity and inclusion. So we do now have a set of equality and diversity champions, and we have set up a diversity, equality and inclusion forum, which will be meeting on a monthly basis. We're going to be pushing through that, the building of our staff networks, and we have got adverts going out for staff network leads, and I have a number of people who have approached me very excited about the work and wanting to do that. The forum is going to be used to share ideas and concerns, generate ideas and development, and input into the strategy development, which, and I want to offer an apology to the board because I had hoped that I would have completed the EDI strategy now and brought it through governance, but capacity has meant that hasn't happened, but it will be coming through the board in the coming months.
Thank you, that's very helpful. And I think in terms of once your staff networks and your forums up and running, we would invite them to your board to share their experiences and their thoughts about how they can be effective for the organisation. So I'm looking forward to that. And I think I'm very keen to explore with the board and with your team non-executive sponsorship of those groups, of course, when they're mature enough and we're mature enough to help. I think that's a really good way of engaging at board level and allowing people to have those conversations and thinking, well, we learn a huge amount about what's going on in the organisation. Thank you. Any other comments, Miriam? Marina, and then Jackie.
Thank you. Thanks, Miriam. Could you just update us on what's happening with the Freedom to Speak Up champions? Any progress with this?
Yes, so we have been pulling together some work, and there is a paper due to go through the People Committee next week, which will come back to the board in terms of progress on that. We have got some ideas about how we can progress that, because I know it's stuck for quite some time, and moving that on has been a challenge. So we've come up with a new suggestion, which will go through the People Committee.
Thank you, and I would make a plea that looks at the whole of Manx Care as an organisation, not just at Nobles.
Absolutely right.
So thank you. Jackie.
Thank you, Chair. Just on the fund, Miriam, I think whilst February 2026 sounds like rather a long way off, it's not. And certainly in terms of financial planning terms, it's not far away at all. And so I think we probably need to consider how we figure out whether is this a function that we need as an organisation on a permanent basis, and if so, how do we go about describing that, scoping that, and putting together a business case for that, because the transformation fund by its nature is only ever transitionary.
Absolutely.
So this team has been around for a rather long time by Health and Transformation Fund standards, and I know that there has been some uncertainty during that time around funding being pulled in and pushed out, and that has impacted on its work. So I think we need to get that visibility and control over the future stability of that team.
I totally agree, Jackie, and I welcome your comments on that, because we're in a situation here where some of those fixed term contracts within that team actually finish next year, early next year. So the team is likely to reduce in size unless we can draw down.
So thank you. So once the paper's gone through our processes here, then I think this is a perfect example of where a board-to-board discussion and then a board-to-board decision can be really helpful.
Yeah,
Does that fit with your
absolutely. I totally agree. I mean, I think Miriam's input over the last 6 months has been invaluable on many fronts. And I think what will come to the board very shortly, once it's been through People Committee, is that honest assessment and that gap analysis of our shared service agreements. Where do we absolutely get benefit from being part of the shared service agreement, and where do we need to supplement and enhance that? And I think that will help shape what ultimately we need in this space. So I think we're lining things up quite appropriately. The board will understand where our shared services is able to take us, what extra we feel we may need as a board in order to deliver our business and support our workforce, and then how we go about delivering that as an organisation. And then we have then got the people and culture strategy refresh, which we're committed to get back into the board in September, following sort of the first year, and on the back of the organisational wide staff survey. So it starts to build, I think, a clear picture, and probably enables us to, as an organisation, which is resource dependent, to be able to really target those interventions, because we probably need less interventions but more targeted, appropriate interventions. So we probably have too many in that strategy at the moment, and we probably need to think about refining them to the high impact interventions, which we know will make the biggest impact across the organisation.
Very quickly, but I think it's timely that we're starting to have those conversations, because the shared services gap analysis that Teresa's just referred to, within that service level agreement, it does refer to provision of organisational development and cultural support directly from OHR, and now that has shifted across via transformation into DHSC. So we've got that separation. So that gap analysis is very timely for us to be having those conversations.
Yeah, that is something I sort of not quite focused, but that's really helpful. And I think, again, from the board's perspective, understanding what risks that puts us at as an organisation is really, really important. So I look forward to hearing that, and thank you. Anything else, Miriam? Thank you. Jackie, March management accounts and discussion of.
Thank you. You should also have in your pack my finance director's report for this. So first of all, in terms of our year-end position, we landed within the £30 million supplementary vote that was agreed by Tynwald. So we as an organisation, individually as Manx Care, arrived at 31 million, and the rest is covered by understands and other things between us and the department. So it's a system to achieve that goal.
So can we just pause there and minute our thanks to your team and you, but also to the wider organisation that helped with that, and the bravery that you had in putting budgets out to people. You're getting clapped by the teams up there. But the bravery and the ambition that we had in putting budgets to a naive group of people, perhaps, who you then had to take through that. So I think it was a significant achievement. It was what was expected, but expectations and ambition don't always get matched by activity,
Delivery.
which I think that was, I think, a big step forward for the wider people that we work with in terms of managing budgets. So thank you.
Thank you. And I think it's all part of, we've discussed it at previous boards. I think it speaks to the cultural shift that's happened in Manx care over the last few years in terms of that financial accountability. And we'll progress that further in this year. I think we've felt that holding people firmly to account for a budget they don't understand and have had no part in building is rather unfair. Whereas this year we have done that. They understand that we may not all agree as to what's in there, but everybody understands how it's been arrived at and what's expected of them. And our enhanced performance measures that we're instigating from this point forward is we've always had an emphasis on what happened and understanding what happened, and now we need to move into, well, we understand why what happened, but what do we do in response to that, and how do we focus our energies on bringing ourselves back into line and back into position. So that's absolutely the emphasis, and I think joining together the performance management and the financial management into a single forum, which Oliver and I are doing, will help to drive that, and making sure that what we actually are delivering and doing is linked to our money. Very often they are two separate things. So that's for next year. I just wanted to take a moment to draw your attention in my report. So we've done some analysis in terms of 30 million overspend is a rather large amount, and I know there's a lot of interest in understanding how that's happened and why that's happened. And so we've done some analysis in terms of what those pressures are, and by a long stretch, the single biggest pressure on our finances are employee costs, and the single biggest element of that is pay awards, and we've discussed those quite frequently, and we expect that to continue. But I think there are some other areas in there that it's worth pointing out in terms of how that spend has increased. So you'll see that we've made significant investments in our services, and that's what's driving some of that additional spend. So that's previous investments in, say, staffing, creating of new services, expansion of services and things that we started last year that we had part costs, and now we've got full costs. So there's a good 8 million in there, which is improvements and moving forward and developing. And I think it's important to draw that out, because I think sometimes there can be a perception that these costs are running away with us and it's all to do with pay awards and inflation. It's not. There are some decisions that we have made in terms of that, and it's that balance between financial sustainability and actually operational delivery and responding to some of the challenges in CQC and all of the other things that we see. Inflation is a big issue and will continue to be a big issue for us. So whilst inflation has dropped in recent months, we will still have catch-up effects of that because our inflationary uplifts have not matched the inflation we've experienced. So I suspect inflationary pressures on us will remain a little bit higher into the rest of the year than perhaps the in-month inflation figures would suggest. It's also worth pointing out in terms of drawing your attention to the SIP delivery in the year. So our original SIP target was 4.2 million, and that was baked into our budget, and we've delivered 8.5 of that. We pulled that number back during the year because we were worried about delivery, but then with renewed effort, we've managed to push that out and achieve even more. The cash out element of that is 7 million. So again, in the context of our additional spend, it would have been a lot higher if we hadn't pushed as hard as we did in terms of our cost improvement programs. And we have to acknowledge the enormous amount of work that's gone on by teams across the organisation in supporting this work. And as Paul mentioned earlier, these are part of those conflicting pressures and priorities that people are trying to manage all the time. So we have to acknowledge and thank those individuals who've put the dedication and commitment into these. I would say that the vast majority, in fact, all of the SIPs that we have done to date have served to enhance services in some way. Not a single one has had any adverse impact on services, and in fact our SIP has in many instances driven a lot of innovation and a lot of improvement. So it's had a much bigger impact, I think, than simply the financial. So that's this year. It's also worth noting that as part of the Back to Balance plan that we agreed with Department and Treasury, certain targets were set for us in terms of savings, and that's on the table in the second page of my report, and we overachieved on those targets too. And so really we pulled out all the stops and did absolutely everything we could to achieve the position we did this year. Clearly going into next year, we start with a position where we're spending what we're spending, which is 340 million is where we landed. We have a budget of 347. We have inflationary pressures that take us beyond that. We have investment ambitions that take us further beyond that again. So therefore, what we needed to do is develop a really significant cost improvement plan for next year, which totals 18.5 million. So there's lots of opportunity in there, and there's lots of those schemes are already partially worked up or partially in train already as part of previous years. But there are a number of others in there that need further work and need further assessment. So as we do with all of our cost improvement plans, we quality impact assess those plans to make sure that we understand what the operational impact of saving money is. And if anything comes out of that that gives us cause for concern or we feel needs a further decision point, then it will be escalated up through the appropriate channels. There are also a number of items in there that haven't been costed and have a level of opportunity for us in this year if we can get them across the ground, across the line. But I would say that in that 18.5 million, that is an enormous target. It's a very ambitious target for us in this year. It total SIP to date since Manx Care began is just over 20 million. So that just gives you in 3 years we've achieved 20, but we started from a standing start and now we're looking at 18.5. So we need to manage that very carefully, and that's how we will. The emphasis this year will be on run rate and meeting your bottom line run rate. I think previously people have seen the SIP as a slightly separate thing. I've ticked the box of SIP, but I've still overspent. And yes, those two things shouldn't happen. So the idea is that focus will laser-like be on you need to meet your monthly run rate target, and that's what we need to do. And that's where all the decisions will lie. So some of the decisions we'll make potentially to achieve our financial baseline, our bottom line, may not necessarily be in the formal SIP plan. There will be operational responses to pressures at that point in time.
Thank you, incredibly helpful. Teresa, first I'll come to Nigel.
Thank you. So I also just wanted to sort of echo my thanks to Jackie and the wider exec team for achieving this position. The board will know we have been at pains to explain why we have overspent and how that overspent has been constituted. So this is really, really helpful. We always knew that the pay awards was a large proportion of that, but also important to recognise the investment in our clinical services fulfills the majority of that. So the vaccination programme, which was previously funded centrally, now we have responsibility for funding that. The expansion in health safeguarding, the sexual assault referral centre being able to be delivered on the island, a really important CSF, ME, long COVID service, expansion in our diabetes service, a mental health recovery college, expansions in primary care. A small amount of additional investment has gone into what would be described as 3 corporate areas, so information governance, risk management and health and safety. But in the grand scheme, they are relatively modest amounts of money, but incredibly important around our levels of compliance and the level of external scrutiny and regulation which sit in those areas. Not only we have a duty as a board to demonstrate our compliance in those areas, we also have an obligation and our duty to our staff and our public to make sure our services are being delivered in a way which is compliant with health and safety standards, information governance standards, and we are managing our risks accordingly. So I think that is really, really important. The final point I just wanted to assure the board on, as Jackie said, we have set a balanced plan for 24-25, which is challenging, but that does mean we're delivering an 18.5 million cost improvement programme. We have established and robust performance management frameworks internally within the executive through the performance and accountability reviews. So this does mean that if we start to drift off track in either our monthly run rates or under delivery against our CIP, there is a process which is enacted immediately in order to respond to that, put in recovery action plans and mitigate that level of overspend. So we've committed as an executive that that starts at month one. You know, we are not going to have this to drift. As soon as there is any deviation from those plans, we put in our established process, which we've tried and tested, and we'll bring those mitigations back through the board. And the executive have all signed up to that.
So thank you. Nigel, any comments from chairing?
Anybody want my job to chair FBC? No, not at all. I love it. I love it. And I wanted to just very briefly acknowledge the immense amount of hard work that's gone into this process, both now and in the past and in the future. And I want to acknowledge the human pressure that the team have been under, because this doesn't limit itself to committee meetings or board meetings. This is constant. And, you know, we are steering a super tanker here. And I've said this many times, where managing change elegantly is very, very difficult indeed. Because once you set your course, if you spin the wheel now, maybe the super tanker will turn in a year's time. And those are the kind of problems we face. So I want to acknowledge that. I want to acknowledge particularly Jackie and her team, the human pressure, the human anxiety that she and her team have been under in worrying and being very concerned about getting this balance right. I think that's important to mention. I also think I'm very heartened to hear that we have certainly been into it in a lot of detail at FB&C about the reactionary approach. So when we see something going off-piste, we will react quickly and we'll bring that about very fast indeed. Bearing in mind that we're already effectively 2 or even 3 months into the financial year as we speak. So the quicker we get into the financial year, the less time we have to react and the less time we have to make changes. I think that's very important too. So that speed of response is going to be key. And I think the other point is a very big picture one. I'm so heartened and I'm very proud of what we are achieving at Manx Care. As somebody who was involved right at the beginning, and I'm sure Sarah would also reflect this, that it's so heartening to see the good work that is being done. And I think that not bringing the organisation in on budget this year could damage our cause below the waterline for the wrong reasons. Because money is one crude way in which we reward ourselves. It is a lubricant, not a propellant. And I've said this many times, but I think that we could fail for the wrong reasons if we don't get this right. And so much good work, pro bono publico, pro bono the island, and on a big picture scale could be damaged if we don't get the budget right. So we need to be very focused in this particular year on that, and we are.
Thank you, Nigel. Sarah?
Just to add to that really, Nigel, I think it is amazing the amount of cash that is coming out of this organisation, and I know that colleagues have acknowledged that, but just to add my additional acknowledgement to that, and thanks to staff who are working so hard to enable that to happen. But we have to face into some very uncomfortable and potentially unpopular decisions now, I think. And I think the board has worked incredibly hard and, presenting to the Council of Ministers some of the really challenging decisions that we will have to make around the money. And, I think we are up for that in order to continue to provide a level of health and social care interventions for the people of the Isle of Man. But we are going to have to make some very difficult decisions that will not always be popular. And I think, therefore, the previous conversation about how do we engage with the people of the Isle of Man to explain some of this, as well as to celebrate some of the things that we do, is really important. Thank you.
Thank you. So yes, I think everyone's comments are well made. I think the board recognises that this is a really challenging financial year. It's a very large expectation in SIP. I know you've got around 300 separate lines in SIP, is it? I think the board would welcome at some stage seeing a sort of aggregated of which areas are we really motoring in, which areas are we less effective in. But I think when we see the operating plan at the July board, we will see some of the impacts of that already emerging. So that's really helpful. I do think that being ambitious and challenging financially isn't just about cost saving, it's also about efficiencies and productivities. And that's an area I think that you've begun to explore in the financial conversation. I think the clinical care groups have begun to explore them, but as you say, it's the beginning of a journey for people. And so we need to talk positively about what our budget can do and where we will need to look at innovative ways of doing things that we don't have budgetary lines for this year. But this year is, I do think, we're 3 years old, where I think somebody said we're like a teenager that wants to leave home. We're out the door, and we need to get that maturity to be allowed to leave home for a bit longer each time. And I think that's what your reflection on last year is incredibly helpful, Jackie. I think that level of insight into what happened will help us have those conversations with colleagues about why it can't happen this year. So thank you. Any other comments from anyone around this? Sana, sorry, you waving me. Apologies. So thank you. There are no items of other business that have been raised with me. Any questions that we've received from the public?
We've not received any in writing.
Thank you, Roger, for sitting through this meeting. I hope you found it informative.
Well, thank you for being so welcoming. Thank you all.
It's a pleasure. It's good to see people in the room. In terms of the feedback and effectiveness, I'd just like to congratulate the exec. We still have some work to do on the length of papers and the purpose of papers, but the clarity, for me as a new chair, is already greater. I think the exec calibre of reporting is really helpful. It's to the point. It's asking us what we want at a board strategically, and as a unitary board, that's really important. So I'd like to thank everyone for it. I'm sorry that we've got people on screen. I can't manage the weather, although I understand from our minister that if we moved the airport to the north of the island, it would never happen. Not sure that's within Jackie's financial gift as yet, but it's clearly something to work on. For those of you who enjoy the TT and are here for the TT, enjoy it. Our next board in public is July the 9th, I think. But I think we're all expected to be hearty and climb hills because it's Tynwald Day the weekend before or something like that. So I'm looking forward to my first Tynwald Day, and we'll report back on activities at that time. So thank you very much, everyone.
Thank you.
Thank you.
See if there's any cheesecake left. Lola's been
You mean it's been left in the kitchen?
left in the kitchen. You better run if you want to.
To see.
Sorry?